The next case is 80-year-old male with laterally spreading tumor of the rectum. It is 40 mm in size and described as LST granular nodular mixed type. We will give the floor to Dr. Yamamoto in the endoscopy room.
Good morning, everybody. I will perform rectal ESD today. I want to show the pocket creation method. But before starting the procedure, I want to introduce my assistant, Dr. Miura and Dr. Fukuda, and commentators, Yutaka Saito and Naohisa Yahagi. Okay, let's show the image. Okay, this is a Fujifilm colonoscope ECL600ZP7. This is a brand new colonoscope from Fujifilm. The characteristic of this scope is it is CMOS, not CCD, and it has flexibility adjuster capability that is similar to the Olympus variable stiffness function. And this is a white light mode, and you can see the LST lesion in the rectum. And when you observe the lesion, you can see the softness by changing the amount of the air. If you insufflate a lot of air, then it is stretched. But if you suck the air, it's very soft. So that means this lesion is not invading. And then I want to show you another function of this scope, that's LCI. Using LCI, you can see a color difference between the surrounding mucosa and the lesion. That means as you can see, the surrounding mucosa is purple and yellowish, but the lesion is more reddish. So this kind of color difference makes the detection of a flat lesion easier. Let's go back to the white light, white light again. With the white light, both the surrounding mucosa and the lesion are orange, but with LCI, the color is different. So it's easier to detect. And after detection, you can change to BLI. This is similar to NBI. And because this scope has a wide range of the focus range is wide, so you just come close to the lesion and you can get the magnifying image, and when it becomes blurred, then you can push one button and then you can focus. This is a step zoom, and if you come closer and then image is not very clear, then next focus. And come closer again. In this way, you can focus easily, and you can magnify up to 100 times magnification. You can see the capillary and flowing white blood cells. Okay, and then let's examine the entire lesion. And when you perform ESD, you have to be able to move the endoscope along parallel to the wall. So that kind of movement you can practice even when you examine with the observational colonoscopy. You should be able to follow the edge of the lesion like this. So keeping a good distance and with a stable movement, that is very important. And you can practice that even during the observational endoscopy. So this kind of smooth and good controlled motion is important. And as you can see, the surface pattern is most of the area is JNet 2A, and maybe some area JNet 2B, but we don't see any area which shows JNet 3. So that means this could have a, superficial mucosal carcinoma, but no area suggestive for invasive carcinoma. So this is a good candidate for ESD. Yutaka, do you agree?
Yes, I agree. And I'd like to ask about the LST subtype, Professor Yamamoto. How about this lesion?
I think this is LST NG, non-granular type. But with BLI and suck the air, it becomes a little bit granular. So the characteristic of this lesion is similar to LST granular maybe, but the morphological type should be LST NG. What do you think?
Yes, I also agree with your opinion.
Okay. Then we know that the extent of the lesion, so in the colon, the extent of the lesion is, the demarcation is very clear, so we don't need to put marking generally. So I will change to the therapeutic scope, and in this case, this is a rectal lesion, so I use a gastroscope. That is let me show the gastroscope I will use.
I recognize that this endoscope has 7 o'clock working channel, but I remember that previous gastroscope of Fujifilm has 6 o'clock working channel.
Yes.
What is the reason why they changed the location of the working channel? Because especially for the therapeutic procedure, 6 o'clock working channel is much user-friendly, especially for short needle type device.
Yes, I agree. So I didn't like the 8 o'clock one. So I requested to move the accessory channel toward the 6 o'clock, but some doctors prefer a little bit left side. So this is the final decision they made.
But in case of using ST food, 8 o'clock or 7 o'clock working channel is also okay because you can centralize the instrument to the central part of the endoscope.
Right. And when you perform the ESD, you should consider the direction of gravity as well. So this is the direction of the gravity. So this is the upside, and this is the downside. And I will start the injection from here. So this is the edge. So the first injection I will do myself. Okay, inject. And this is the mucus. And after making a good protrusion, then I ask my assistant, Dr. Mueller, to stick the needle. And just the base of the protrusion, so you are sure that you are injecting into the submucosal space. Okay? Please do not inject into the muscle layer. That makes the procedure much more difficult. Okay? And I think this is enough to start initial incision and dissection, like this. So I will make just a little bit more here. I will make a mucosal incision about 2 centimeters. And then I will create a pocket. I will show you that.
After developing pocket creation method, do you usually start your procedure from the proximal side? I mean, anal side in a straight position, you don't have to keep the retroflex position anymore.
That's correct. Because once you go into the submucosal space, you don't need to insufflate air at all. So you can collapse the lumen. So just a straightforward view is good enough. So I will make a bit distant, about 5 to 10 millimeters. And then this is an end cut. I'm using Bio 3, and this is an end cut eye. End cut eye effect 1, and duration 2, and interval 1. And then I can cut the mucosa like this and make sure I'm cutting okay. And I will cut a little bit more.
This is very important technical tip to open the submucosal space.
Yeah, you can use the sheath, the tip of the sheath, to
and
lift
a little
up.
bit to lift up the
Yes.
edge of the inside
Yes.
area.
Then you can avoid cutting the muscle layer.
Hello.
And after that,
Hello,
using the
Yamamoto
water
sensei.
jet, and you can go into the submucosal space, and you can see the submucosal space clearly. Then you can continue.
Hello, Yamamoto sensei.
Yes?
So I'm Haru speaking. So very nicely dissected. So my question is, scene is very interesting. So your assistant controls the needle, is that right?
Yeah, my assistant is controlling the knife. So in this way, I can concentrate on the
Just
endoscopic
handling
control.
the endoscope.
Yes.
So you control the mother endoscope and also a pedal of the energy is you controlled.
Yes. Then I can see the muscle layer here. Can you see the muscle layer?
Yes, yes.
Okay. And if you see the muscle layer, then you can change the direction. Then you can avoid cutting the muscle layer. And here is the blood vessel. So if you see the blood vessel, you can cut around the blood vessel and isolate the blood vessel. You can leave the blood vessel. Okay, then you can see the blood vessel. And I change to the 0.7 spray coag, and this is dry cut. In this way, you can avoid the bleeding. This is most important. The prevention of bleeding is most important for the successful ESD. Okay, then after you see the muscle layer, it's better to add some injection. In that way, using a mucoap, you can elevate the submucosal tissue selectively. I mean, the submucosal tissue right above the muscle layer is very soft, good submucosal tissue. I can elevate that area, that layer.
So, Professor Yamamoto, are there
Yes?
any tips for when the lesion on the folds? So, in order to make a pocket creation method, are there any difficulty when the lesion is located on the folds?
Okay, when the lesion is located on the fold, then you can climb up the fold and press down, and you can control the direction, any direction. You can see the muscle layer. So place the needle, and if you cut in this way, that's dangerous. But you can change the direction then you can avoid. So that kind of adjustment can be made any place. So even when you are on the fold, you can do the same. And without noticing such a prominent fold, you can overcome the fold by just adjusting the direction. And I can show you the progress. So this is the region, and I go in, and this is the depth of the pocket. So I measure the depth of the pocket and compare with the from the outside, and this is the edge, so it's almost there. And how about the lateral side? This is the lateral side. So I can see the lateral side. I can see the pocket here. And that lateral side is also almost okay. So I will dissect a little bit more to the oral side. Okay, this is the muscle layer. So avoid the muscle layer and dissect. And I have to be careful not to cut the blood vessel. But this is a very small blood vessel, so slowly cut it. That's probably okay. And okay. And this is another blood vessel. This is a little bit larger, so I will pass and dissect. This is small, so I can go slowly. And then this blood vessel, I change to the spray coag with low voltage and whitish. Then I cut with dry cut. Okay? And then change to the swift coag again. Then I can dissect. So once you come into the pocket, you have a very stable condition. And even if you make some bleeding inside the pocket, don't worry. You just place the bleeding point by the tip of the hood and you stop the bleeding temporarily. Then you can exchange the device to the coagulation forceps and stop it. In that way, you can keep the operation field clean without blood. So this is the blood vessel. Avoid the blood vessel and dissect around the blood vessel. Isolate the blood vessel, and then spray coag and make it whitish. Okay, then cut it. In this way, you can avoid. Okay, I want to show you what I did. After creating a pocket, then I open the pocket from this side. This side means that is the downside in terms of gravity. And then dissect, dissect, dissect. And the oral edge, I go around from the left side, and I finish the oral side in this way.
The strategy of additional mucosal incision is very important for this technique because in case of starting the additional mucosal incision from the upper side according to the gravity, inside the area comes down according to the gravity. Then the following mucosal incision at the lower side will become very difficult. That's why Dr. Yamamoto started the additional mucosal incision from the lower side according to the gravity.
Yes. Then I can dissect. So basically, I try to dissect to the direction I can see. In this way, you are sure where you are cutting. Then you can come out. Okay. Okay, now I am opening the right side of the pocket. When you open the pocket, you place the needle inside the pocket and cut the submucosal tissue to the mucosal incision. In this way, you are cutting from the muscle side and move parallel and go to the luminal side. So this is the safe direction. Then after making enough mucosal incision, I extend the mucosal incision. So I check the edge of the lesion and then I make a mucosal incision. And make sure I'm going to the right direction, a bit too far maybe, so coming back. But here is another, okay, then I will go this way. Okay, then I open again. So in this way, uh, you can avoid cutting the muscle layer. And even if the procedure becomes difficult at this stage, that's the edge of the lesion. So only the lateral margin becomes positive. So lateral margin is not that important compared to the vertical margin. And this is the blood vessel. So I coagulate. Then coagulate again. Then I change to the Swift coag. Okay. Then I keep dissection and finish the procedure.
So keeping the tissue on the upper side according to the gravity, still you can use the gravity effect, but it is very effective. In case of dissecting here first, following submucosal dissection sometimes very difficult because of the fluffiness of the remaining tissue.
And in this situation, the ability to move the tip of the endoscope very precisely and slowly along with the curve of the wall is very important. So this kind of, a bit longer, yes, this kind of movement you can practice even when you are doing a diagnostic colonoscopy. So you can practice ESD even during the screening or diagnostic colonoscopy. Otherwise, you don't have enough chance to practice ESD, I guess. Especially at the beginning of the training, you don't have enough chance to train. But just imagine you are doing ESD during the ordinary colonoscopy examination, you can practice this kind of movement.
Professor Yamamoto,
Yes?
we have a question about pocket creation. When do you do lateral incision? Do you do that after complete creation of pocket?
Yes. I,
So you always
I,
finish creating.
I always do the lateral mucosal incision after creation of the pocket. And at least I finish the most important part, dissection of the most important part.
That means middle of the target region.
Yes, that's correct.
Thank you.
So this is the end of the procedure. So cut this tissue and I finish. Okay, that's it. Thank you.
Thank you very much for showing
Thank
us
you.
this.